So welcome back from the break, folks. We're actually pretty close for on schedule for these meetings where we're got a lot of packed information. Um, we're going to transition to um, some the last segment of this morning's Business of Pediatrics extended webinar. So we'll be chatting a little bit about evolving back to school guidance, what telemedicine looks like on the other side of the pandemic, and some post-election analysis and implications for kids and pediatricians. So first up, we're bringing up Dr. Nathaniel Beers. Dr. Beers is Chief Executive of the HSC Health System, trained as a primary care and developmental pediatrician, and there aren't too many pediatricians who have Chief Operating Officer of a large urban public school system on their resume. So, but with the evolving pandemic and changing guidelines about back to school participation for kids and families, we invited Nathaniel to provide some framing, analysis, and updates. So, Dr. Beers, thank you for helping us out.
My pleasure. So we're going to talk a little bit about sort of safe return to school, right? Lots going on in that space right now. These slides were produced a week ago, so there's some updates even from there as the community spread continues to grow in our region. And so we will update those as we move through. I don't have any conflicts. We're going to talk a little bit about the AAP guidelines, what the current state is, and this, unfortunately, was my edit miss, how the plan affects us here in this region, not in North Carolina. So in June, the AAP released its statement around school reentry because we felt like many school districts were moving forward with plans taking into account the infection risks, but not the impact of lack of in-person instruction was having on the whole child. And so we advocate that all policy considerations for the coming school year should start with the goal of having students physically present. That continues to be true, and as we gain more data, we continue to update that. And in fact, there will be an update of this statement that will be coming out probably mid-December with additional data there. A part of the reason is that we actually know that there's huge racial and socioeconomic inequities that have occurred with COVID. Certainly, we know that the impact of COVID on Black, Latinx, and Indigenous communities has been greater with increased prevalence as well as increased severity of disease. And those patterns have played out in both adult and pediatric populations with data out of Children's National as well, bearing that out locally. We also know that there has been issues with access to virtual learning with a greater degree of difficulty in access to devices as well as internet and appropriate spaces to learn in Black and Latinx and Indigenous communities as well. There is new data that is about to be released in the DC area that does show dramatic impact of virtual learning on educational attainment. As well, and so you can you look forward to seeing that unfortunate data as well. Again, showing that in fact, for white and high income families, they actually have been making more progress than they would have made. For Black and brown communities, we have seen slower progress and gaps has been growing instead of decreasing. We also know that over 30 million children and adolescents rely on free and reduced lunch as well as breakfast and supper programs. And so adequate nutrition is a major reason that the AAP is advocating for in-person instruction. And we also know that one of the variables is certainly around the quality of school facilities and that the ventilation systems in schools will be a barrier to return to school, and that the way school funding models are in place have disproportionately impacted school facilities in Black and brown communities and poor communities, meaning that the ventilation systems and the school systems are often not well set up for that physical return. And so there are investments that are needed in those spaces. So where are we today? Today, about 37% of the entire country are in virtual learning. It seems a little bit odd for us to be having that conversation given the fact that here locally, almost everybody is in virtual learning spaces except for some small populations as well as those in private school. Nationally, 63% are in person at least part of the time, with 37% all in person and 25% hybrid. In addition, we look at the data out of Brown and this self-reported data from school districts, and we do see that student case rates nationally continue to be below the community case rates. However, the teacher case rates have slipped up and are higher than community case rates. And so that will be something that we need to continue to work on, because part of reopening safely means that we are keeping teachers safe as well. And we'll talk a little bit further about some data that we need to keep in mind as we think about the impact of teachers and COVID. So what's going on locally? Certainly most of our public school systems, as I noted, remain closed for in-person learning with some exceptions. There's some early childhood and special education in Fairfax. There was an expansion that was scheduled to happen in Fairfax yesterday that did not happen. And Loudoun County has also been able to open in some pieces. Arlington, Alexandria, DC have all tried to create some opening plans. All of those have been pushed back. And DC has opened some CARES classrooms, which are not providing instruction, but providing a site where families who need extra support and need a space for a child to learn can leverage that. And so we'll continue to look at that. The good news for us is that student and staff rates in the DMV do remain below community rates. Though most of this data, again, is out of private schools where they've been able to do testing and social distancing that may be more difficult to do in public schools. So what are the guidelines that the AAP put out, and what are sort of the major takeaways that we need to be thinking about? And so certainly communities need to be taking all necessary measures to prevent spread. You will see more and more pressure from the AAP to acknowledge that we have prioritized the opening of adult facing activities before we opened community facing activities for children relative to childcare and schools. And so there will be more dialogue in that space, and certainly that data coming out of our local health departments does suggest that the areas that people are experiencing spread are in those restaurants, bars, and gyms, and certainly those are not serving our children well. These policies need to be flexible and nimble. Certainly as case rates go up in the community, we need to be responsive to that. And also there is new information as we learn more and more about COVID. We need to be more aware of what the plan should have in place. One thing is not going to be enough. And so we'll talk about the multi-layers and multi-prongs that need to be in place to make sure that students, teachers, and staff are all being protected. They need to be revised and adapted based on levels of viral transmission. Clearly, there should be coordination with state and local public health authorities, school nurses, pediatricians, as well as other health experts. They also need to be practical and feasible and appropriate for a student's developmental stage. That plan that may make sense at the early childhood or elementary school level may not make sense when you look at the middle or high school level. And so there need to be adjustments to acknowledge the different types of instructional patterns and school movement patterns, as well as the different needs that students may have and the different capacity that students may have to be compliant with plans. We also need to make sure that we're taking into account special considerations and accommodations to account for the diversity of youth, including vulnerable populations who may have additional exposures. We need to make sure that we're working collaboratively and developing accommodations when needed, particularly for our kids with disabilities. And we'll talk a little further about what does that look like. These school policies, however, need to be guided by supporting the overall health and well-being of all children, adolescents, their families, and the communities. This includes making sure that they're available in languages other than English to support those families who need other languages in order to understand the plans, and that there are going to be additional funding resources that are needed to make sure that all the safety measures and support of educational needs are in place, whether students are in person or in virtual learning environments. And that includes advocacy that the AAP has been doing both at the federal as well as state and local levels. So what are the guidelines? The physical distancing guidelines continue to be that CDC guidance of 6 feet distance between desks or kids when feasible, recognizing that that is going to be more difficult in younger classes. It is incredibly important that that distance is maintained between adults. More and more data out of schools as well as out of health systems is that adults are spreading it more likely between each other. The places they are more likely to do that are not actually in patient rooms or in classrooms, but in break rooms or in places where they are away from children because they let their guard down, they take their mask off, they get closer than 6 feet to each other, and they aren't following through with those guidance that we would recommend. And that is the spaces that we have to make sure that people are careful in. Clearly, for younger kids, it's going to be better if we can cohort their classes, meaning that the kids don't move, the teachers move to decrease crossover. Clearly, making sure that there is adequate spacing if there are desks in the room, as well as cohorting in the elementary school. Recognizing that most middle and high school students at the secondary level are moving from class to class. Making sure that we're doing things to minimize traffic in the hallways, so minimizing or eliminating lockers, as well as increasing space for those activities that may increase exhalation. So certainly physical education, as well as classes that may involve singing or choir or band, all require additional space and preferentially are done outdoors. Busing continues to be an issue and limiting factor for many school districts because it does require that we take into account physical distancing as well as recommendations for face coverings. Ideally, it means additional routes, scheduling times differently at the start of the day. But the first thing that schools have to do is figure out what's possible in their buildings and then use busing as a secondary strategy to address that issue. We've talked briefly about hallways already, but it's really about reducing traffic, thinking about flow patterns, thinking about how to minimize that. How often are kids going to the bathroom? How many classrooms can go to the bathroom at one time? All of those are pieces that are about managing the hallway. Meals in cafeteria, as we noted, school meals are incredibly important for kids, but that is going to require us to use other spaces besides just the cafeteria to make sure that we can maximize distancing, given that people can't wear masks when they are eating, and so using classrooms as well as other spaces in the building, as well as eating outdoors when possible. Playgrounds are a space that have been created lots of questions, and so certainly it is going to be difficult to maintain physical distancing when outdoors, so using face coverings is incredibly important, as well as cohorting to make sure that you are reducing crossover during those periods of time to reduce the risk. What are the current face covering and PPE guidelines? We do recommend universal face covering for school for all children over age 2. Most children, including those with disabilities, can wear masks with practice as well as good adult modeling and breaks during those days. Those breaks should be scheduled, ideally, to try and allow kids adequate time, certainly frequently during the day, ideally outdoors if possible, but making sure that it's not happening at times where kids are going to be running around and more active, but is a time when kids are going to be quiet, sitting still, and not moving throughout the space that they're in. As I noted, it's critical that staff are wearing those face coverings, and then we need to take into account that there are some circumstances where cloth face coverings make it difficult for learning, and so in early childhood, as well as English language learners, as well as special education situations, including those who are deaf or hard of hearing, need to be able to see the lips in order to learn. And so there are newer models of clear face masks that fog up less than some of the previous models, and some new strategies that schools have been putting out that do allow us to move forward in that space. For procedures in schools, we are still recommending that you follow the CDC guidelines, which have been updated throughout the summer to acknowledge additional information as it's come forward. Cleaning and disinfecting, so clearly we're all washing our hands a lot, and so that should be happening at school as well. We should be reducing high touch areas as much as possible. That means doors, railings, faucets, and so they need to be cleaned at least daily, but ideally people are touching them less. We need to also recommend that high touch areas outdoors are also part of the plan. And so that means thinking about that railing coming in and out of the school. Any of us who've gone in or out of schools know that kids dangle all over those. And so making sure that they are part of that cleaning plan. And if playground equipment is being used, it also needs to be part of that cleaning plan going forward. What about ventilation? This has been getting a lot of news and certainly resistance by people who are concerned that the aging school infrastructure is not prepared to deal with the ventilation issues. And so certainly optimizing those systems is important to increase air circulation. Clearly outdoor activities as much as possible, opening windows and doors as viable, recognizing that that's not always possible depending on the climate and depending on the building. We do not recommend the use of portable fans, however, to increase ventilation. Those portable fans are going to blow particles throughout the classroom, and so they are going to increase rate of spread, not decrease it. What about screening and testing? This has been a hot topic, and certainly part of the new guidance will work on trying to increase the information that is in this space. Temperature and symptom screening at schools may not be feasible in person, but many schools districts have moved forward with screening tools to help make this possible. And so regardless, we want to make sure that parents are keeping their children home when they are sick, and staff should be staying home as well. Data out of Florida suggests that in fact more staff are showing up sick than students. And so we want to make sure that that is something that is addressed as we think about looking at our schools locally. We still are not recommending testing prior to school reentry, as it only gives a false sense of security, though you will note that many local schools that have opened have done testing prior to school reentry. It has not been terribly helpful in making determinations about who should and shouldn't be in school, as it's only a single point in time. Staff or students with symptoms, as I said, should be encouraged to stay home, but if they do show up at school, they should be encouraged to connect with their medical provider to discuss a need for testing. The challenge, as we all know, is that the list for symptoms for COVID is essentially covers almost any childhood illness. And so it is difficult for us to differentiate. And we can expect that particularly as we enter into flu season, that we will see escalation in this space. And so more kids will be sent home from school, and more schools are likely to require clearance from pediatricians prior to return. We're going to talk just briefly about the CDC criteria, just so that we have all of those available to us. The current CDC criteria is that children can return to school if they have confirmed alternative diagnosis and are afebrile for 24 hours without fever-reducing meds. Recognizing that there are some conditions that have already been documented to be able to occur concurrently. And so there are reports of both flu as well as strep throat occurring concurrently with COVID. And so having one of the two of those does not necessarily confirm that there is no COVID in a patient. If there is not an alternative diagnosis, that child needs to be 24 hours without fever-reducing meds. Respiratory symptoms need to have improved, and they need to have been at least 10 days since the first symptoms. If they have had testing and have no symptoms, they can return after 10 days. In addition, if they have 14 days after exposure to a known contact, that means that in households, it's 14 days after that individual has been deemed non-contagious. So at least 10 days from their onset of disease, as well as the additional 14 days for a total of 24 days, which is an incredibly long period of time, but is the current space that we're in. Now, there are some movement in this space, and there are some countries around the world that have started looking at shorter quarantine periods, recognizing that the vast majority of people are actually showing up within the first 5 to 10 days. And so there may be some movement in this space as we move forward. The other piece that is important to note is related to sort of keeping schools open and who to quarantine, and data that continues to be monitored in this space, because in schools where they are doing physical distancing as well as face coverings, there does seem to be very limited transmission in the school building. There have been cases in the building, but very little transmission in the buildings. which brings up this issue around, well, do schools stay open or closed? The original recommendations that came out of the CDC and were quickly taken down. There is not much guidance to support schools in this space at this point, is that when an individual in one class is positive, the class should be closed for cleaning. And any appropriate quarantine for any students who had substantial exposure, meaning at least 15 minutes within 6 feet, which that means most of that class would meet quarantine requirements. If more than one individual in the school was impacted, they recommend closing the school. Again, this may be different in different school buildings. That may be true in an elementary school class where students are not moving throughout the building. But for those schools where students are moving, it may be enough to have a single individual who's moving around the building may have increased exposure. And so all of those come in play. This closing a district, if there are cases across multiple schools, is the area where there is the least consistency in sort of what the right recommendation is going forward. What we are clear about is that we should be acknowledging that the evidence of transmission, if control measures are used, continues to grow. That we should be doing isolation of sick individuals and contact tracing and cleaning of spaces. And the cleaning of spaces typically means leaving a space vacant for 24 to 48 hours and then cleaning that space prior to return. And so in most situations, you're talking about making sure that there's at least 2, if not 3 to 4 days where that space is unavailable, and then regrouping at that point, depending on sort of whether or not there are additional cases in the building. What about mental health needs? And so we certainly know this has had a huge strain and stress on children as well as staff. And so we need to acknowledge that students' needs are very different this year. They may not be ready to learn when they show up in the building. There's certainly increased anxiety, kids with decreased attention span, increased rates of traumatic stress, as well as additional mental health needs that may have bubbled up during this time period. We also need to make sure that staff are having their needs supported, and certainly that has been a major focus of school systems to make sure that they are trying to support their teachers who have had to pivot multiple times during the last year to make sure that they are supporting their students, but they won't be able to teach our students and support them effectively if we're not supporting them as well. So I mentioned that we would talk about children with medical complexity, and so clearly the major issues are making sure that we're planning, connecting with the patient, family, medical team to make sure that there's an ongoing dialogue, knowing that those plans need to be based on what's currently available, and that often it requires some changes. Certainly reviewing the IEP or individualized education plan as well as individualized health plans if they exist. Will be critical, but acknowledging that the child may be very different than the last time this plan was written or reviewed. And knowing that our goal as pediatricians is going to be working together with families to reduce but not eliminate risk. Every single decision we're making right now is inherently got risk involved, and so we need to make sure that we're reducing those risks as we move forward together. So how can we do this together, right? So part of this is making sure that we're keeping up to date on decisions in the school area so we can support our families, as well as making sure that we're up to date on the rate of COVID-19 in the community. And I would say that locally, it is relatively easy to do for DC and Maryland. In Virginia, it does require going to each local health department in order to get a sense as to what those case rates are. But the data is there and is important for us to be aware of. Certainly, we want to ask patients and students, as well as their parents, about what their experience has been with their schools. If for those with disabilities, we want to connect with the school nurse to make sure that we are helping to support that reentry plan, because often these kids are left off the list of students who should be returning to school. And then making sure that we are using the resources in our community to support the mental health needs of our patients and their families, recognizing the additional strain and stress that they have all been under. And so here are some resources, including the tracker tool that I showed earlier around sort of the number of school districts that are open virtually, but I'm happy to take any questions at this point.
Thanks, Nathaniel, for a great overview. there are one or two questions in the chat box, and this is a national and local work in progress, and even locally there are differences between DC, Maryland, Virginia, and it's pretty challenging, I think, for all of us. But we do have a minute or two for questions before we tee up the telemedicine panel. Do you have a chance to scan those questions?
Sure. So I think the first, there are a couple questions around sort of testing, right? And I think the AAP does have some guidance on testing. It has not been crosswalked into the school return, and that is part of the work that we literally are doing this week to try and sort of crosswalk that testing recommendations relative to the return to school. And so I hope that will be helpful for people as they look at that. I think that the concern that people have with the rapid tests are about the accuracy and whether or not a negative test can be left alone as a single negative test, or whether it warrants a follow-up PCR test in order to be a confirmatory test. And so that has varied very much from school district to school district, depending on what the local public health department has required. And we see huge variation around the country on that. And we are hoping to weigh in to try and give pediatricians some tools on how these should be used going forward to make sure that we can provide some backup for schools in this space. And so I recognize that, and hopefully we will get some clarity coming soon from the AAP in that space. There is a question as well around testing for return to school for kids without a close exposure. And so the current recommendations are only excluding kids who have had a close exposure. So someone who they have spent more than 15 minutes within 6 feet are the kids who should be excluded. And so we are not recommending a wide scale testing for kids who have not had that level of exposure. So the sibling of a child who was exposed is not considered a close exposure unless that child who was exposed has developed symptoms and or test positive. And so those are, again, some components to take into consideration. There is a question again around, does every child with a runny nose who's not really sick need to be tested for COVID? And there's, again, huge variability about what schools are allowing to come in, or child cares are allowing to come into their schools. Many are kicking them out for 10 days, and that is their sort of solution unless there's a different diagnosis. And that's super burdensome for families. And certainly for us as pediatricians, we're being burdened by asked to clear kids to make those determinations. And different pediatricians around the country, there's a very active conversation about this on the SOPM listserv that's been listed. The Council of School Health for the AAP has been having a very active list, and there are some guidance around the country that local chapters, including Georgia, New York, California, Florida, have put out and on publicly available on their websites that do talk about sort of flow charts of who should get tested, who doesn't probably need testing, and giving a little bit of cover for pediatricians to recognize that probably every child doesn't need to be tested. But I did not get to all the questions, but certainly feel free to email me if you need, just at nbeers@hschealth.org, and I'm happy to engage if there's additional questions that you have.
Or you can push the questions to us at PHN, and we will be glad to connect them to Nathaniel. And as everyone acknowledges, this is still very much a work in progress. We appreciate the leadership and perspective the AAP and that Dr. Beers and others are sort of bringing to impossibly challenging situations that keep changing, but we are getting there bit by bit. We are getting there. So let's all try to work together.